For this video, we will be discussing GERD, or gastroesophageal reflux disease, and the three primary groups of agents used to treat this very common condition. But first, we're going to spend some time going over the mechanism of acid secretion in the stomach and how GERD actually happens. So as I said, the mechanism of gastric acid secretion occurs within the stomach, which is a very complex glandular organ. And it's guarded by two sphincters to keep that acidic environment contained, except for when food must pass from either the esophagus through the lower esophageal sphincter into the stomach, or from the stomach to the small intestines through the pyloric sphincter. And for today, we're really just going to focus on the lower esophageal sphincter, and you'll probably hear me refer to it as the LES moving forward. So all throughout the stomach, there are cells that secrete mucus and bicarb. This mucus and bicarb is to protect that mucosal lining from this acidic environment that's contained within the stomach. But in the body and the fundus of the stomach, we actually have parietal cells that are responsible for the secretion of the hydrochloric acid that leads to that acidic environment. In this same area, there are chief cells, which are responsible for the secretion of pepsinogen, which in the acidic environment is converted to pepsin to aid in chopping up all those proteins that are ingested. So our final group of cells we're going to talk about are found in the pyloric region of the stomach, and they are known as G cells. And they secrete gastrin, which is going to be important moving forward because it's a hormone that can trigger acid secretion. Moving to the next slide. Because we are talking about the mechanism of acid secretion in the stomach, the parietal cells are going to be the main focus of today, and that is the cell that I'm showing you here. So these parietal cells express hydrogen potassium ATPases, or proton pumps, on their apical membranes, which is a primary active transporter for protons. Keep in mind, at resting conditions, aka when you aren't eating, you don't need the secretion of gastric acid because there's no food present to be broken down. So because of this, there are very few hydrogen potassium ATPases found on the membrane surface. These are instead held in the cytoplasm, ready to be used whenever needed, so whenever you eat your next meal. But in activated conditions and during feeding, as many proton pumps as possible will be inserted into the parietal cell membrane. And then inside the parietal cell, water and carbon dioxide will combine to form carbonic acid. This will further split into a proton and a bicarb ion. Now the hydrogen potassium ATPase will pump this proton across the apical membrane of the parietal cell into the GI lumen in exchange for the catalysis of ATP to ADP as the source of energy. So potassium ions are also moved from the GI lumen into the parietal cell to try and compensate for this loss of this positively charged proton. But unfortunately, these potassium ions, once they are inside the parietal cell, will just move from inside to either back into the lumen or back into the interstitial space. So they will not stay there. So in order to maintain that electroneutrality of the parietal cell and compensate again for this loss of that proton, a chloride ion is first pumped into the parietal cell in exchange for that bicarb ion we mentioned earlier. And then the chloride ion is pumped into the GI lumen. And now the net charge change is 0. And once the proton and chloride ion are in the GI lumen, they can become hydrochloric acid or gastric acid. So now that we understand the cellular mechanism behind acid secretion, what are the signaling components actually controlling these processes? So the first chemical that stimulates acid secretion that we're going to talk about is acetylcholine. And acetylcholine is a neurotransmitter that is released from the nearby enteric nervous system. And acetylcholine will bind and act upon the M3 muscarinic receptors of the parietal cells, and this will lead to the movement of calcium ions from intracellular stores into the cytoplasm, ultimately triggering this hydrochloric acid secretion cascade. Another chemical capable of controlling acid secretion is gastrin. And gastrin is secreted by those G cells found within the pylorus of the stomach. And gastrin is a peptide hormone that is secreted from these G cells in the stomach that will bind and act upon the cholecystokinin type B receptor of the parietal cell. And in a paracrine signaling fashion, this will also lead to that movement of calcium ions from intracellular stores into the cytoplasm, again triggering this cascade. And the last chemical we're going to discuss capable of controlling acid secretion is histamine. And histamine also acts in a paracrine manner, and it is released by several types of immune cells that are components of the GI tract. So histamine will bind H2 receptors or histamine 2 receptors of parietal cells, leading instead to an increase in cyclic AMP, which, similar to calcium, will still trigger this cascade of gastric acid secretion. So these three chemicals are all released in response to either actual feeding or the sight and smell of food. So moving to the next slide. Now remember I said that we are focusing on the mechanism of acid secretion because many of the agents available for GERD focus on modulating this physiologic process. But surprisingly, the pathophys of GERD is not necessarily from acid hypersecretion, but it's actually from other causes that actually affect the lower esophageal sphincter or the LES tone. So GERD is kind of the same thing as heartburn or acid reflux, but it's much more consistent, frequent, and severe. So gastric acid is what causes and exacerbates GERD, which again is defined as that persistent or repetitive acid exposure to the esophageal mucosa. So in order to first get this initial esophageal lesion, something needs to impair the sphincter. And what's really important about the LES is it is really the primary defense against gastric acid for the esophageal mucosa because it does not have these mucus or bicarbonate secreting cells to protect it from that caustic environment. Now, when I say this impairment in the lower esophageal sphincter tone, so this can be caused by a number of things, including alcohol, poor diet, smoking, certain medical conditions, and many medications. So once we have one of these initiating factors on board, and it leads to this initial lesion from acid exposure, once this lesion is actually present, there's this vicious cycle of continued acid exposure, a worsening of this lesion, and then further harm to the lower esophageal sphincter from that acid exposure. And this leads to GERD having much worse complications like Barrett's esophagus or perforation. So unfortunately, we really don't have any agents to improve lower esophageal sphincter tone, but we do have agents to combat this acidic environment in the stomach. So moving to the next slide. So as I've alluded to, the primary strategy employed for GERD treatment is the reduction of gastric acid. And the class of agents that are used first line are the proton pump inhibitors or the PPIs. And these are things like omeprazole, which is also Prilosec, pantoprazole, which is Protonix, and several others. And what's notable is they all end in this prazole ending. These agents act as irreversible inhibitors of gastric acid hydrogen potassium ATPases. And typical daily doses actually reduce daily acid production by about 80 to 90%. So each of the PPIs are administered as a prodrug. meaning they need to be converted into their active form before they can be effective. And this activation actually occurs in the presence of acid. So once the PPI is administered and absorbed into the parietal cell, the drug begins to accumulate in this area where that acid is going to be secreted initially. The acid will catalyze the formation of a positively charged active form of the drug. And because of this and pH trapping, because now that it's positively charged, it can't escape across the membrane, the drug is now stuck inside of the parietal cell so that it can now covalently bond with the proton pumps that are inserted in the membrane and cause this irreversible inhibition. So PPIs are a powerful tool for inhibiting acid secretion because it is the last step in this acid secretion cascade. So for instance, if you were to block acid secretion over here, you could end up with receptor upregulation over here to try and compensate, or you could get upregulation of one of these two signaling pathways to overcome that inhibition at one of the other receptors. But by targeting this last step irreversibly, there are few ways in which the system can actually circumvent the PPI's mechanism of action. So because this inhibition is irreversible, further acid secretion is going to require the synthesis of new proton pumps. So we're going to have to wait for transcription, translation, and insertion into parietal cell membranes. So acid suppression is actually prolonged even though these drugs' half-life is pretty short. One important thing to note, though, is PPIs have to be given about 30 minutes before a meal. And it's generally the first meal of the day because you need to give the drug sufficient time to actually accumulate in this region within the parietal cells where they'll be exposed to that acidic environment to be activated. And remember, acid secretion is only stimulated during feeding. So overall, PPIs are very well tolerated. However, long-term they have been associated with bacterial overgrowth in the GI tract, leading to pneumonias and C. diff infections, magnesium and vitamin B12 deficiencies, and osteoporosis because of this loss of that acidic environment, which is needed to maintain the appropriate gut flora and the absorption of some vitamins and minerals. The body, in some cases, tries to overcome this proton pump inhibition by secreting more gastrin to compensate. But because we're inhibiting that last step in gastric acid secretion, it doesn't lead to an increase in this secretion, but instead leads to hypergastrinemia. And this can cause morphological changes in the GI tract and potentially cancer. So because of these long-term risks, recently many efforts have been taken to try and limit the length of PPI treatment in patients, but it still remains the treatment of choice. So moving to the next slide. Now, before we move on to our other more established agents, I do want to take this opportunity to introduce a novel class of agents known as the potassium competitive acid blockers, or the PCABs. And this would be agents like vonoprazan, which were recently approved as another acid suppression therapy option aiming to circumvent some of the pitfalls of PPIs. So specifically, our PCABs and PPIs both interact with our parietal cells, hydrogen potassium ATPases, to inhibit that final step in acid production, providing that superior potency and efficacy to other agents, but with some important differences in their mechanisms of action. So we just went over the PPI's mechanism, so keep that in mind, and compare that with our PCABs, which actually act reversibly and lead to ionic competition with our potassium ions that are required for that proton exchange. So this rapid and competitive reversible action is an innovative attempt to overcome some of the limitation of PPIs. So first, PCABs generally have a faster onset of action compared to our PPIs that provide rapid acid suppression, and they also inhibit acid secretion in a reversible manner, allowing that pump to return to normal function when the drug is metabolized or eliminated. So we have that quick on-off effect, which allows flexibility and might help with on-demand symptom relief, and if there's any reason to discontinue, the off switch is faster, allowing acid suppression to return to normal. So PCABs are also acid stable, more so than the PPIs, so they can be taken with or without food. So again, more flexibility and other benefits we won't get into necessarily on this slide. And then obviously the primary downside is going to be expense because they are new, and also with this newness comes a lack of a track record of safety compared to our PPIs. But these may still provide some additional clinical utility for certain patients. So moving on to the next slide. So the second class of agents we're going to talk about are the H2RAs, or the histamine 2 receptor antagonists. And these act to inhibit gastric acid. So we're going to safety slide. And then obviously the primary downside is going to be expense because they are new, and also with this newness comes a lack of a track record of safety compared to our PPIs. But these may still provide some additional clinical utility for certain patients. So moving on to the next slide. So the second class of agents we're going to talk about are the H2RAs, or the histamine 2 receptor antagonists. And these act to inhibit gastric acid secretion by inhibiting the H2 receptor. And these agents include famotidine, cimetidine, and used to be ranitidine or Zantac, which was withdrawn recently because of safety concerns. So all of these agents are going to end in tidine, and they all closely mimic the chemical structure of histamine, where these agents are going to try and outcompete histamine, the endogenous ligand, for this receptor, block its binding, and then eventually prevent gastric acid secretion. So the H2RAs are less potent than PPIs because they are earlier in the signaling cascade controlling acid secretion. So any sort of upregulation of these two pathways could be able to compensate for this inhibition. These agents are really selective for the H2 receptor, so they're really not going to bind the H1 receptor, which you probably associate with allergies with a very high affinity. And these receptors are primarily expressed in the gastric mucosa, so these agents are pretty specific. So the newer H2RAs are generally very well tolerated, but cimetidine was the prototype H2RA, and it has a slew of drug interactions and adverse effects, and it is one of those dirty drugs that you're probably going to hear about often. So cimetidine has countless drug interactions because this H2RA inhibits many of the CYP enzymes, altering the metabolism of many drugs, and it has a countless list of side effects, mostly because it has a lot of off-target effects. So generally, this agent is no longer used for this indication, but can be seen for some of its off-label uses that have to do with its off-target binding. Now, regardless of the H2RA chosen, there are two problems that occur with this class of medication, and that is tolerance and rebound. So tolerance to these agents can occur in a few days because of that hypergastrinemia that I mentioned with the proton pump inhibitors. But now this hypergastrinemia will actually lead to an increase in gastric acid production, providing a sort of escape route to this histamine receptor inhibition. So rebound can also occur with these agents because the body is going to try and compensate for this blockade with receptor upregulation of these histamine 2 receptors. So if you go and abruptly stop these agents, all of this histamine can now bind more receptors, leading to an amplified signaling to secrete gastric acid. So they will have to be tapered off of an H2RA if for whatever reason the patient needs to stop this agent. So though these agents are not as effective as PPIs, they are still helpful in the treatment of GERD and are over the counter and pretty common and also pretty cheap. So moving to the next slide. So moving on to our last group of agents, we're going to discuss the antacids. So typically antacids consist of either aluminum hydroxide, magnesium hydroxide, calcium carbonate, or sodium bicarbonate, some sort of mixture of these agents, and they are marketed under a number of brand names like Maalox, Mylanta, Tums, etc. So antacids act as chemical antagonists to neutralize gastric acid, and typically their effectiveness is expressed in some sort of milliequivalent of acid neutralizing capacity. So in general, these agents are pretty well tolerated. There are some considerations. So one component can be the sodium bicarb, which is very effective, but it can easily be absorbed and cause acid-base and electrolyte imbalances, which is particularly concerning with renal and cardiovascular disease. And another example of a consideration would be with calcium carbonate, which is rapid and effective, but it can cause rebound acid secretion. And this is because, remember, calcium triggers acid secretion. So calcium from, let's say, Tums can get into the parietal cells to then trigger this cascade, again causing that rebound acid secretion. So in general, just remember they're pretty well tolerated, but they can be overused because they are over the counter, and this can pose a risk for some patients. So with regard to drug interactions, there's two main concerns here that are associated with the antacids, and this is the alteration of gastric pH, which can alter the rate of absorption of drugs, and also these agents can sometimes chelate drugs in the GI tract, like we discussed with the bisphosphonates, decreasing their absorption, so these drugs would likely have to be spaced out and taken separately. So in terms of the use of antacids, they are really good for symptomatic relief of heartburn, but they're not really as effective as H2RAs or PPIs and really shouldn't be used for GERD treatment. But it isn't uncommon for patients to sort of lose track of the frequency of their heartburn and not realize they are really experiencing GERD and be relying on their Tums all day and night for relief. So moving to the next slide. So I hope this video has demonstrated the advantages of PPIs and PCABs over H2RAs and the roles these three groups of agents we discussed today fall in the treatment of GERD. I also hope this video has highlighted the important clinical considerations of each agent that is dictated by their pharmacology, as well as our new and up-and-coming class of agents to be aware of.